Okay, good morning, everyone. We are on day 4 of Colloquium Week, and we have a presenter today who is going to talk about a topic that is, crosses over many disciplines. It's not unique to just nursing,
Oops.
because tomorrow's presenter will be able to just share your screen again there, Lorraine, and go to your presentation. Um, but the topic of retention in the discipline, right, and the profession, I should say, and that is how do we keep folks who've gone through preparation to become a certain profession, in Lorraine's case, it's nursing, to become a nurse, and what causes these individuals within usually, 3 to 5 years to be burnt out and leave the profession, and now all of their preparation to become a nurse was sort of lost, and the money and all that stuff that they had to pay for tuition. So, why does burnout happen? And so, it's a very important topic. That, like I said, cuts across many different professions. So, Dr. Hover, I think what I'll do is just turn it over to you at this point and let you begin.
All right. Thank you, Kevin. I appreciate it. And good morning, everybody. It's wonderful to see people here, and thank you for coming. Um, as Kevin said, I'm Dr. Lorraine Hover, and today we're going to talk about a topic that's often been called nursing's dirty little secret, and that is lateral violence. So the presentation today is based on my dissertation research um, and its impact of lateral violence or bullying on new nurses and their decision to remain in the nursing profession. Excuse me. I have a little bit of allergies going on, so please forgive my little hoarse voice. First, let me just kind of introduce myself. As I said, my presentation is based on my dissertation research, which was conducted between November of 2019 through March of 2020. And I was fortunate that my um, research was finalized, at least the interviews were, before COVID hit seriously. I have presented similar topics, and I just finished one last week to the International Society of Psychiatric and Mental Health Nurses. And I'm awaiting publication along with my dissertation chair, Dr. Gail Williams, in the International Journal for Human Caring. So, who am I? Well, I'm a nurse of 36 years, and I have been an educator at the bachelor degree for the last 10 years. I've been with Aspen just since December of 2020. Now, this research is real near and dear to me because lateral violence is so against what nurses do and who nurses are that it's hard to think of a caring profession being someone or having this lateral violence, this bullying, this eating our young going on. I would like to add to the body of knowledge so that we can eliminate lateral violence in nursing. I hold a bachelor's degree in nursing from the College of St. Scholastica in Duluth, Minnesota, and both my master's and my PhD in nursing are from the University of Phoenix. Besides nursing, which, if you've seen my byline, my signature line, nursing is not what I do, it's who I am. But other than nursing, I like to spend time with my family, read, make greeting cards, and watch the Minnesota Vikings. And don't comment about bad seasons. I've been there. Today, what I want you to take away from this presentation is to identify 2 reasons why nurses may decide to remain in the nursing profession despite experiencing this lateral violence, and be able to relate this lateral violence to negative physical and psychological effects on the new nurse, and discuss at least one lateral violence prevention strategy that nursing leaders, educators, and really anyone can use to advocate for students and new nurses as they transition to professional practice. For those of you that are not in nursing, I hope you can take some of this information away and bring it to your own profession. Let's take a quick look at the background of lateral violence, so it kind of gives you an idea of why this is so important to study and to understand. During my literature search, the very first documentation of lateral violence that I found was a 1909 New York Times article where Dr. Leon Harris wrote to the New York Times talking about these horrible conditions that nurses were suffering that impacted patient care. In fact, he likened what the head nurses or the charge nurses were doing to the students and new nurses to conditions in a Siberian prison camp. And he said that this was causing his patients not to do well. Subsequent articles, various doctors from around the area, New Jersey and Pennsylvania specifically, wrote in and said, hey, Dr. Harris, we're seeing this too. So it's documented in 1909. Jump ahead to 1983. And Roberts was the very first person to apply theory to the condition of lateral violence in nursing. So we've got this big gap of 74 years where there's not a lot of study on this whole issue. Roberts applied Freer's oppressed group theory, and we'll talk a little bit more about that in just a little bit. 1985, the very first academic paper analyzing lateral violence was published by Smythe. And then we started seeing the phrase eating our young being used. This was actually first introduced by a nursing professor to talk about how the nurses and the nursing profession was just tearing apart and eating our new nurses. This became kind of the term that was at least well known in the nursing profession. Also in this article, this professor talked about like a bucket of crabs. You put all these crabs into a bucket and one starts to try to climb out and get away from it and they pull them back down. And that's how this professor theorized this lateral violence was. In 2002, Conti O'Hare introduced nurse as a wounded healer. And we'll talk a little bit more about this theory as well. But basically, nurses' superpower or their power to heal came from healing their own wounds first. And then in 2018, the American Nurses Association introduced the End Nurse Abuse campaign. And I was fortunate to be in on this committee to help make these guidelines for this campaign. So what the heck is lateral violence or bullying? We all probably have our ideas of what it is. But these behaviors can be divided between overt and covert. Now, we see this long list, and we're not going to go through them all for obvious reasons. But the highlighted ones are what Griffin, who is one of the key researchers in lateral violence in nursing, has published as the 10 most frequent forms of lateral violence: scapegoating, infighting, snide remarks or verbal affront, sabotage, withholding important information from this person, undermining them, betraying trust, backstabbing, nonverbal innuendo, like raising the eyebrows, rolling the eyes, and failure to respect privacy. Now, some of the ones that we think about, like name calling, intimidation, ethnic group jokes, are all there. But perhaps some of the biggest ones that really impact patient care directly is that withholding information. One of the reasons is they have found that nurses may withhold information from this other nurse to kind of see them fall flat on their face. But that information they withheld has to do with a patient. And so that safety factor that we keep talking about in nursing education is not there because that poor nurse doesn't know the information. And that directly impacts the quality of patient care and patient outcomes. So taking a look at all of these different behaviors, I'd like you to share in the chat box any comments that you might have that you have seen concerning lateral violence or bullying or something that you've seen at your work, or have you seen it? Give you a few minutes to think about that. Wow, everybody's not, oh yeah, I've seen it the past 34 years. Eye rolling. Patricia, I'm so sorry that you've been a victim of this. Eye rolling, yeah. Okay, so we do have quite a few not helping others, and a lot of nurses towards nursing students. That is true. And unfortunately, it also happens between educators. And there's a lot coming out about educator on educator violence. Creating division, that's a good one, Kevin. Thank you, everybody, for your comments. And that just kind of shows us that this happens far too frequently and far too much. So why is lateral violence important to know about, to research and understand? Every country in the world that has done studies, or I shouldn't say done studies, that has even commented in newspapers. In every continent, well, except Antarctica, because the penguins haven't discovered this whole lateral violence thing yet. But every continent, every culture, every religion has reported some form of lateral violence against their nurses. We're not talking patient on nurse violence or visitor on nurse violence. This is nurse on nurse violence. So it's very pervasive. And as we witness nursing students, educators in the nursing profession, it has happened and it's pervaded our what's supposed to be very caring profession. So it's a very profound phenomenon. Now, the statistics that I'm going to give you are pre-COVID. There's not been, it's hard to really look at the effect of COVID and lateral violence yet. We're going to be seeing the fallout of that later. But prior to COVID, studies showed that up to 90% of nurses have experienced some type of lateral violence in their career. Scary part is a third, at least, of new nurses leave the entire profession in the first 3 years of professional practice. They've taken up to 4, 5, 6 years to get their nursing degree, and they leave within the first 3, most of them within the first 2 years. Lateral violence has been shown to increase suicide rates. Nurses are already at an increased rate or risk of suicide. UK studies showed at least 4 times the risk of the general population. The United States doesn't really research or keep track of nurse suicide. So the specific stats that I found were in the UK. Lateral violence also impacts the ability to be engaged in your work, be that as a student, as an educator, or as a direct care nurse. This produces the decreased or even inability to not only express empathy, but to experience empathy. This makes a disconnect with our patients. So here we have a nurse who just can't connect with the patient. And as we know, that connection between nurse and patient is so vital in the healing of that patient. The nurse who is the victim of lateral violence also um, decreases or even inability to advocate for their patients or even for themselves. And as I discussed, it decreases retention rate. Maybe the nurse doesn't leave the profession, but a vast majority of new nurses will leave their first job, and somewhere around 2/3 to 70 to 3/4 of new nurses will start to job bounce during the first year or two of being in professional practice, trying to get away from or finding a way to find that safe and caring environment that we all want and need in nursing. So, what was the purpose of my research? Basically, I wanted to explore and understand the lived experiences of new registered nurses who had experienced lateral violence and but decided to remain in the nursing profession. There was all this research out there about why nurses left. What are maybe the causes of lateral violence? How can we mitigate lateral violence? What are the effects of lateral violence? And yet I could not find a single study that focused solely on why did nurses decide to stay? I mean, if 90% of nurses are experiencing lateral violence and 1/3 of our new nurses are leaving, why are that other 2/3 of those new nurses remaining? We need to understand that aspect in order to understand the whole aspect of lateral violence in nursing. So my study, I interviewed using semi-structured one-on-one interviews, 9 new nurses. Obviously, they all had to experience lateral violence and decided to remain in nursing. Graduated within the last 36 months from a pre-licensure baccalaureate program. And I chose, you see the difference between graduation and began practice. I did that because at the time that these nurses were graduating, it wasn't unusual for new nurses to start having some difficulty finding their first job because so many hospitals were not just BSN or bachelor degree preferred. It was, if you don't have a bachelor degree, you're not going to get hired. So there was that time frame difference. They had to live in central and southern Arizona, and I gave a wide age range because so many of our nurses that are graduating are second, third, even fourth career. And one of my nurses that participants that I interviewed, she was in her 50s when she graduated with her baccalaureate in nursing. Besides being outside of these parameters, the other exclusion criteria was that they previously worked as an LPN. I basically wanted people that didn't have a lot of experience with lateral violence to understand their experience. As you see from my demographic data, I had a wide range. My youngest was 22, and my oldest was just turning 58. Good mix of marital status, good mix of ethnicity. 5 of the people that I interviewed held non-nursing degrees, and 8 of the 9 had prior college experience. And you see there about the RN obtained and when they began professional practice. So how did I framework this research? You know, a lot of times it's just on one theory. Well, I ended up using 2 theories. One to understand why lateral violence happened, and one to understand the lived experience that my participants had gone through. So oppressed group theory. as applied to nursing by Roberts in 1983, really looked at the hierarchical structure of the nursing profession. Remember, nurses for a long time were not the well-respected profession. And nursing came into being at a time when women were not necessarily held with esteem either. But we also have that hierarchy where not only do we have the structure of, the charge nurse and the manager and, on up through the chief nursing officer, we also have the hierarchy of nurse and physician, because the physician must provide the orders for the nurse to carry out certain functions. What has been found is, in many instances, that the group that's on the bottom is feeling oppressed. And that oppression can often turn inward first, almost to a self-hatred, and then it turns outward in these behaviors of lateral violence that we've seen. This same theory of Frere's oppressed group theory has also been applied to racial discrimination. So it's not strictly nursing, but an oppression overall. Nurse as a wounded healer is the one that I really use to understand what these nurses were going through. As I mentioned, Conti O'Hare said that past wounds had to be healed, or at least addressed and started to be healed, in order to empower nurses to care and to heal. We've heard a lot about nurses' superpower, and our superpower is caring and healing. And Conti O'Hare has brought up that these past wounds that are being healed give us that empathy and caring to help bring it to our patients. But when these past wounds, past traumas are not addressed, they are unhealed, it translates into the lateral violence behaviors that we've seen. I used a qualitative research method because, frankly, there's no way that you can figure out what the lived experiences of people are if you don't ask them, and you can't quantify that data. So it was strictly qualitative. It was descriptive phenomenology. And I wanted the participants' voices to be heard, their words to give meaning to what the phenomenon was. And as I said, I used semi-structured one-on-one interviews to kind of understand, not only to give structure to myself to asking questions, but then to allow the participant to lead the conversation after those first initial questions. In phenomenology, the researcher is not only the tool for the research, but they're also the collector of data, but then they become the student because you're interviewing the expert. So you're learning from this expert about what their experiences were, because only that person knows exactly what they went through and what they felt. Then the modified Stevic-Kalasi-Keen method was used for data analysis. And this long word basically means you listen, you listen, you listen. You record it, you translate it, you read, you read, you read. I swear sometimes I was dreaming about these people's words because I had read them so many times. But only through that reading and that rereading can you start seeing those different themes emerge. But you also have to watch out for your own bias. We all have implicit bias. We all bring bias to whatever it is that we're looking at. And so reflective journaling and just looking at what my own biases were before, during, and after this research in order to make sure that, as I'd like to say, no bias was brought in, but at least minimal was brought into the interpretation. Also, every participant was sent a transcript of the interview so that they could add, subtract, reinterpret for me. And 3 of my participants did add further information and clarification. So what were the themes that came out of this research? The first one was the patients. This was spoken of by all 9 of my participants. They didn't want to leave their jobs. They didn't want to leave nursing because they were committed to patient care. They said that the only objective nurses should have is taking care of patients. And that includes collaborating with other people. They needed the experience. Many said this was another main reason for staying. They had difficulty finding their initial job, but also perhaps they didn't want to look like, as one participant put it, a flake by job jumping. But they also saw it as a chance to gain experience in order to move on to better things. I got counseling. Many used this to cope with what they were going through. 5 of my participants had been diagnosed with PTSD, and all 5 of those that were diagnosed with PTSD also talked about suicidal ideation. So what they were experiencing was so bad and so damaging to their psyche that they thought about ending their lives. There was an end, not end to their life, but there was an end to what was going on. They said that knowing when this was going to end helped them to cope. One nurse needed to stay there for 9 months in order to get a certain certification she needed. Another one needed to stay 6 months on the unit. She had been a long-term employee with this hospital system, and their rule was when you take a new job, you have to stay there 6 months before you can transfer. So they saw this endpoint as being able to move forward. A couple of them even likened it to being pregnant, going through labor, and then the endpoint, or the prize, if you want to call it, is that baby at the end. Well, in this case, they went through nursing school, they got their license, they're going through this horrible experience, but there was an end in sight. I cried. It was a release of their emotions. It was a release of frustration. And some talked about it being a relief that they could get this out. Tears that are cried in frustration are actually found to have chemicals in them that get released from our body. They talked about not wanting to cry in front of the perpetrator because they didn't want to have backlash from it. And then the theme that I think that should be the most disturbing to nursing leadership, and really to any of us, is nothing changed. They talked about reporting the incidents over and over again, multiple ways to multiple people, moving up the chain of command, and yet nothing changed. One person said it changed for a couple weeks and then went straight back to where it was. They felt silenced, voiceless, and powerless. I want to share some of the words that were shared with me. Well, first, let's talk about endorsement. As you see, patients and the experience were talked about by all 9 of them. I got counseling, and there was an end by 8 of them. And I cried, and nothing changed by 7 of them. So the words of my participants. the patients. And then think of the patients. Isn't that why we're supposed to be here in the first place? Patient care suffers when nurses are at each other. Our energies need to be on the patients, especially ones getting ready to have a baby. Nobody wants to give birth with a bunch of people fighting around them. They also talked about how this broke down the team and how this further impacted patient care. They saw errors. They even admitted to committing errors because they were afraid to ask questions. Patient outcomes were affected. One patient that one of my participants spoke of ended up in ICU because of one of those withholding information things. So truly the impact on patient care is there, not just, I don't want to say just, but not only the nurse, his or herself, but on patients. The experience. They needed this experience. I had to get experience in order to do something different, something better. I got on with a hospital first thing out of school and I hated it, but I needed to stay there for that experience and not to look like a flake. And then she went on further talking about how this hospital experience was needed for her to get her what she considered her dream job. She wanted to be working in subacute rehab and with geriatric patients in long term. But she needed that hospital experience to be able to move forward with that. I got counseling. I ended up seeing a counselor. She told me, well, oh hell, that I showed signs of PTSD. Who the hell gets PTSD doing a supposedly caring job? Obviously, nurses do. If I hadn't had counseling, I'm not sure I could have made it. And she wasn't talking about being a nurse, and she was talking about her life. She said if she hadn't gotten that counseling, she would have killed herself. I hate to admit this, but I felt suicidal. The more I got bullied, the worse I felt. My therapist saved me. She's using techniques used with PTSD sufferers. To think on that, that is so weird to me. They spoke a lot about PTSD and how suicidal ideation came in, that the more this happened, the worse they felt. And it just was this oppression, this moving down. They felt smaller and smaller and smaller. And the more it happened, the worse they felt. This also triggered a lot of physical problems. One person already had an autoimmune disease and had a major flare and ended up having to be in the hospital for it. Another one was hospitalized for behavioral health issues. And, and just, I don't want to say just, but of course, receiving the counseling as an outpatient. What's interesting is that some of the nurses did not realize that their employer had an employee assistance program, and the ones that did were afraid to use it. They were afraid of the repercussions, that it might get back to their employer, that might get back to their boss and make things even worse. There was an end. I could see that there was an end, and I knew there was an end point. This was not permanent. Better things would come, and I believed that. For me, the end point was being able to leave with some experience. Knowing it would end helped a lot. Having that finish line in sight made it bearable. This particular participant is a runner, and she had just completed one of her very first marathons. And she said, when I start thinking about it, it's like those last few miles of a marathon. You're totally spent, but you see that finish line, and you just know you can make it. Same with going through this experience. Isn't it just awful to think about? They're equating this thing to labor. They're equating this to running a marathon, and that they had nothing left, but they knew something had to get better. I cried. I cried every single day. I'd go in the bathroom to cry, or even into a patient room. You just go to the bathroom, cry, and move on. You know what? I cried almost every single day. I was heartbroken. Why are they so mean to new people? That one really struck me. Why are they so mean to new people? They want somebody to come in and make them feel welcome, make them feel cared for, make them feel safe so that they can grow. And they did not experience this. I just gave up. I felt like I wasn't heard, like I felt nothing would get done. Nothing changes. She didn't have a voice, even though she reported things. She was the one that said that anytime anything was reported, all of a sudden the whole floor knew who had reported what. So there was no safety. There was no caring there. It just became fodder for the rest of the unit. You know what? You're told to take it up the ladder of command. I call BS. Nothing ever changes. One person even spoke to the chief nursing officer, and the CNO kicked it back down to the manager, saying they're the ones that you have to deal with. No accountability in these changes. And everyone that spoke of nothing changed also spoke of knowing that zero tolerance policies were in place and obviously were not enforced. So I want to hear your reactions. Tell me, what are your reactions to this? Did anything surprise you? What are your thoughts about what these nurses talked about? Unfortunately, for many of us, it is not surprising, Patricia. That is true. It can seem that way, Kevin, that the culture is too powerful to overcome. But believe it or not, inroads are being made. There is light at the end of the tunnel, and it's going to be a long time coming, but we can overcome this culture. Any other thoughts before Jennifer? Yeah, I believe that it's true. When I first started thinking about my topic, this was 10 years ago. It took me 10 years to get my PhD. It wasn't as much talked about or dealt with, and it's greatly improved over the last decade. Yeah, it makes them think it's normal. Good for you, Patricia. You were outspoken about it. Having that stronger personality and being able to speak up for yourself is wonderful. Anne Marie, I agree. We can make changes with who we are teaching now. That's the way I feel about it. That if I can teach now and let them know it's not normal, that they don't have to put up with it, that we can change the culture one new nurse at a time. Yeah, blind eye with holding anybody accountable. And that's certainly not a good leadership. Patricia, definitely. There's something that some hospitals have put into place. I didn't say hospitals, just that happened. All these nurses were in the hospital setting. They call it, some places call it a code white. And that means that somebody is being bullied, something's happening to them. Sometimes it's physician on nurse, sometimes it could be a visitor on nurse, but those in the surrounding area will come and stand in silent support of the person that is experiencing the violence. And I think it's a wonderful way to show support um, while it's happening, to show the perpetrator that you don't have to, you're going to be held accountable. And I agree, you can speak up and still be very professional. That's a great point, Patricia. And we must always remain professional when we do speak up. Thank you, everybody. That was very interesting to read. So obviously, when it comes with research, you want to make recommendations. I think it boils down to promoting a healthy work environment, a culture of safety and caring. And I am so pleased that I see this actively endorsed here at Aspen. Um, it's talked about, we're constantly told that we're supported and cared about, and it's seen from every level of management. We need dedicated education on lateral violence, not only with our new nurses coming up in nursing school, but continuing on throughout the career of the nurse. We need dedicated reporting procedures that remain, I don't want to say anonymous, but confidential. And there need to be trained investigators into this, and preferably investigators that have nothing to do with the unit that's involved or the area that's involved. And of course, we must enforce our zero tolerance policies equally and consistently. For nursing education, we must make the culture of safety and care be normal. That this is what is expected, and you don't have to put up with anything that is outside that safety and care. I also believe that we need that dedicated module or modules on lateral violence for faculty, staff, and students to know what to look out for, how to respond to it, how to report it, and what we can do to end it. We already do, once we get back into, real life clinicals, debriefings, of course, happen at the end of a clinical day. But we also need to concentrate those debriefings on the atmosphere, the reaction of other people. Did you experience any of these things? What could you do? What can we do? And if there is incidents of lateral violence reported in the educational arena, we need, again, to report it immediately, a consistent and immediate response to all reports, and to hold the facility responsible as well as ourselves. As we know, just because you're a good nurse doesn't mean you're a good leader, and all leaders need some training. And that training should include how to deal with and how to prevent lateral violence. I am a big supporter for residency programs for new nurses as they transition into professional practice. And those preceptors that work with these new nurses must be specifically trained to be preceptors and trained in lateral violence. Confidential reporting investigation of all lateral violence reports must occur, and an accountability must be there. And then we must provide care and support for all victims of lateral violence. I talked about a lot of the psychological problems that occur: depression, suicide, feeling bad about self, decreased ability to have empathy. But people with chronic pain, chronic stress, we know what chronic stress can do to people. Physical ailments have come about. People have developed a lower resistance to illness. And right now, we're still in the midst of COVID. So you got a lowered immune system, you might be at greater risk for COVID. Future research has to continue, and I want it, all methods have to be done. We need to know numbers, but we also need to know the experiences, and we need to do mixed methods. We need to do case studies. We need to do literature searches, qualitative, quantitative, so that we can understand lateral violence in its entirety. We need to know more about why nurses decide to remain, because that's going to give us the key points to look at to help build up in our new nurses that resiliency that we talk about. Nurses have to be resilient. We have to be creative. But how can we use that resiliency and creativity to battle lateral violence? You need to look at varied education backgrounds, different geographical areas, varied experience levels. I only looked at new nurses. Who are nurses that maybe have lots of experience but are new in an area being treated? And we not only need national studies, we need international studies. I only found one in the literature at the time, and that was by Bambi et al., and it was Italy and the United States. There's been comparisons between data, but Italy and the United States in this particular study use the same parameters, the same terminology in order to look at lateral violence and see how maybe culture played a part in education, etc., played a part in lateral violence. We need to understand the knowledge of and the use of EAPs. If all of these nurses were afraid to use EAPs, employee assistance programs, why? Well, they talked a little bit. I wasn't concentrated on EAPs, but they told me that they were afraid to use them. They're afraid it was going to come back on them. So how can we improve that? How can we understand overcome this fear? The United States needs to look at nurse suicide more closely. There's starting to be more research into nurse suicides. And I think the pandemic has had a lot to do with that. I've seen a lot of up and coming research in nurse suicide. But once we're done with the pandemic, are we still going to be interested in the topic? We need to continue to understand the stressors that nurses go under. And then we have to look at the PTSD, Lateral Violence Association, that is there. When all 7 talked about psychological problems, and 5 of them talked about PTSD, specifically, there's something there. We need to understand it. And how can we apply this? I hope that this will have you come away with an intentional awareness of what your own behaviors are and what the behaviors of others is. That this will prompt you to take care of yourself, but also caring behaviors towards others. Can we do more to promote caring in our work environment? There has to be a dedication, a personal dedication, as well as a facility or organizational commitment to safety and caring. We need to promote advocacy. How can we advocate for those that may be not able to advocate for themselves? And we need to stay informed. What's the new research on lateral violence? What's going on in our own area? What's going on in a more global arena? So one last official question before I take questions. What one thing will you do in response to this presentation to continue to promote a culture of safety and caring in your own environment? Speak up for those who cannot speak for themselves. Be professional. Yes, draw attention to it when it occurs. Mentor and support new employees, definitely. Because research has shown that it's not just new nurses, it's oftentimes nurses that are new to an area. Teach others how to address it. Safe zone, I like that, safe zone to report incidences. Where is our safe zone? Have we created that? Oh, definitely, Jennifer. Encouraging new grads to feel free to ask questions and that help is available. That is so vital. Don't be afraid to ask questions. It's okay to not know the answers. You have to get away from, I'm out of nursing school, I know everything. Or even as instructors, I certainly don't know everything. It's okay to say, I don't know, but we'll find the answer and we'll find it together. Case studies are a great idea, Kevin and Sherry. Case studies on lateral violence and how that impacts patient care and patient outcomes. Yeah, me too. Ask questions, ask questions, ask questions, because we can't possibly know everything. Yeah, exactly. Patricia, when you say we can experience it from our students, yeah, sometimes we can. And we have to be strong and say, you know what, that is not appropriate behavior as an upcoming nurse, as an upcoming professional, and it's not okay in my classroom. But also then give them ways to maybe it's they're angry about a grade. How can we teach them then to come to us and say, you know, I don't agree with this grade. Can you show me? And that way we can, you know, help groom them for those other questions that they come up with. How can you frame it in a more caring and safe manner so that I will respond appropriately? As a conclusion, you know, I wanted you to identify, relate, and discuss. So I think all of you have done that. Thank you. We must remember that this is a pervasive phenomenon in nursing and in many other professions, and that it's destructive to the nurse, to the nursing profession, to the facility that it's in, to the patient, and to the healthcare system. If we think about it, all of us are touched by nurses in one way or another. Nurses impact every aspect of a person's life, including public health. We've seen that so abundantly this past year. So, what impacts the nurse impacts the health of all of us. So, questions?
Dr. Hover, I just want to say thank you real quickly before you get hit with some questions. And I know sometimes people are collecting their ideas at this moment. So sometimes this gives me an opportunity to share some of my notes and the things that I felt jumped out at me. And I do want to let you know that you know, lateral violence, which really is just a hostile work environment. It's illegal, by the way, but lateral violence is not unique, as you mentioned, to nursing. I, you know, used to work in school districts and, you know, have been an educator, and teachers will treat each other that way too. It is almost an overwhelming experience to be in that kind of culture. And there is this feeling of helplessness where, you know, it's just too big to try to change. One person can't do it, you know, and if you don't feel like you can get support, then it makes it even more intimidating. But I took these, this was one of my initial notes, one of my initial thoughts, and you really hit it as a core theme. And it was the number one, you know, point that you hit, and I appreciate that. And that is that this behavior, while we may think, hey, it's nurse on nurse, that nurse on nurse behavior has a direct ripple effect on our patients.
Mm-hmm.
And that right there should be the number one question that we always ask ourselves. And we would do that in education. What is best for the student? You know, if you two are bickering right now, what is best? Is that in the best interest of the student, right? And y'all do this now on what is the best interest of the patient. You know, and that can kind of be the driving model, because it is the reason why you become a nurse, is to get in and care for that patient. And you would do nothing that would interfere with their care. And if our behaviors towards each other is interfering with our attitudes and our focus and our care, and even in some situations you mentioned, which was shocking, you know, I won't report this medical error because of fear of being bullied. I'm scared of being, the mob scene will overwhelm me if I report this error that was committed, you know, against my patient. So I can see how that can be so overwhelming that it's difficult to change and people want to leave, you know, but you really did a great job on asking a creative question. You know, most of us want to go look at, okay, here's all the people who are leaving. Let's go ask them why they left, right? Whereas you said, I want to look at why are all the people staying, right? We have, you know, 85 to 90% of the people have experienced this. Well, what about the 10 or 15 percent of the people who never experienced lateral violence in the nursing workforce? What's going on there? Let's go see what's happening there. You know, is it at least leadership maybe has set that tone? So I think that's an interesting area. And then also, you know, of the 2/3 who stay in the profession, you know, why did they stay? So I do think that was an important question you asked, and was very creative. And I do like the idea where you said that there's this theoretical model out there called the nurse as a wounded healer. And that's a very powerful idea there, because we're saying a nurse is a healer, but understand that the nurse is also wounded. She's a healer, he's a healer, but it's a wounded healer, because they have they're a human too. They have life outside of that profession. And then there's problems sometimes and challenges within the profession that they cannot just shed off when they come in to heal you. They are coming in with their own wounds as they're trying to heal your wounds. And I just thought that was a very powerful idea on how to framework, you know, the sort of the concept of a nurse. But you touched on 6 core themes in your study. And you did mention that sixth theme, again, if I keep reporting it and nothing changes, then you have this learned helplessness. And we just learn to tolerate the status quo, which may not always be ideal. You know, I'm curious too about, since we were saying there is a direct impact of this behavior of lateral violence between nurses that ends up rippling onto our patients. Is there any research out there that has investigated the patient perspective of nurse on nurse lateral violence, where they may have witnessed this in the room or heard something out in the hall, or, you know, was in the birthing room and was watching people fight and bicker, and what impact that had on the patient and their experience and their impression? And then I was curious if there's any research out there that interviews the aggressors and interviews what are their motives, and why are they thinking that this is acceptable? Because that is another interesting variable in this triangle. You have the aggressor, the victim, and the patient, so to speak, right? And we often go look at the victims and we forget about the perpetrator and the patient maybe in this research. So I hit you with a whole bunch of stuff there. I'm sorry, but those were my notes. Very, very interesting topic, but I wanted to also give folks the opportunity maybe to generate some of their own questions. So maybe you can just
Well, one thing I wanted to address with you,
based on my thoughts.
there is emerging data because, you know, there's the HCAHPS, which is the, you know, surveys you get after you've been in the hospital. And there's been data off of that, but there is emerging data on patient perspective. And there has been actually a decent amount of research done on why perpetrators continue to perpetrate. And one of the overriding themes that I've seen in the research on perpetrators is that I went through it, now you have to. It's a hazing kind of a thing that happens very often.
There is some power in mob rule, unfortunately. We as most creatures, they want to fit in. It's not good to be
Mhm.
an isolated individual in terms of safety and protection, so to speak. So we often will go towards the group, and unfortunately, sometimes that group can be full of perpetrators. Did anybody have
Yeah.
any other questions, maybe, or comments about your experiences as a nurse, and maybe things that you learned maybe in your preparation as a nurse, your nurse prep program, maybe something that happened in your first year, like are there new nurse orientation programs in hospitals, for example, that may have talked about this and you noticed it made a difference? Anybody had any of those personal experiences to share?
I guess this is Dr. Raber. I guess one of the things that comes to my mind is that when students are doing their clinical rotation, and I've had, as when I was a clinical instructor, I had several conversations with students at post-conference about why is this nurse so mean to me? Why doesn't she like students? And so on and so forth. And it would be interesting to me to see how we as the clinical staff can report that appropriately without the fear of losing the clinical site. And I really feel like this is an ongoing issue in many facilities. What are your thoughts about that, Dr. Hover?
Well, I think that's unfortunately very true, especially with the limited clinical environments that we do have. We're um, with patient stays. Again, this was prior to COVID because COVID shut down most clinicals, if not all of them. Um, when I was being trained to be a nurse, people were in the hospital 10, 15 days. So it was, hospital stayed fairly full. But now we've got more nursing schools going after clinical time. And so it's hard to get those clinical experiences for our students. So we're very protective of that. But we have to also remember that we want the best experiences for our students. So there has to be a trust relationship that develops between the university and the clinical site that, hey, what do you want us to do when somebody's inappropriate with our students? How can we handle this? Um, and I haven't always seen that with that relationship between site and university. Um, it's another aspect to this whole thing that we need to change.
Yeah, what a great question, Dr. Raber. I think that just showed how, kind of political even some of these changes are when we can address, something that's occurring. And in the bigger picture of things, as soon as you said that, I'm sure there's someone who makes a decision. Do I jeopardize this clinical partnership because this person is complaining that someone was mean to them? Or do I just say this person just got their feelings hurt, and which one is bigger, the clinical partnership or someone who just got their feelings hurt? I'm not saying one's right or wrong, but you get my point. They are going to weigh which one is more significant of damage, losing a partnership, or someone just went into the bathroom and cried for 5 minutes. Now they come back out and that's normal and we all do it, right? You see how people have to sometimes weigh those things, and not jeopardizing a clinical partnership may outweigh someone just getting their feelings hurt.
And you also brought up something, Kevin, about um, what level of violence are we going to tolerate compared to um, what are we teaching our students? you know okay, well, this nurse was mean to you. Well, that happened. She probably was, he or she's been having a bad day or whatever. um, that's just teaching the student then that it's okay to be that way because there's an excuse for the behavior. So there's is always that balance that we're looking at, and this is a very touchy topic because we don't want to lose our nurses because we are in a nursing shortage.
Yeah. And there is a lot of research out there about observational behavior, like you just mentioned. I observe others doing this, and therefore I learned to do that just by watching others and knowing that it's sort of as acceptable or normal. I do believe a lot of it starts with education. I think Anne-Marie even mentioned that somewhere, where if we can have things within the curriculum that actually bring up examples of lateral violence and then some strategies for dealing with it. It's different to say, okay, we know it's here, here's a big problem, everybody look out for it. But if we don't say, okay, I finally found it, what do I do? You know, then there isn't really a solution that we can implement to help sort of minimize it over time. It is a long-term goal. It can't be anything where one little silver bullet's going to change this. And it's because there's been generations of folks who have been indoctrinated into this mentality of lateral violence towards one another. I mean, you mentioned stuff as far back as the 80s, some of the research, which kind of blew my mind, you know, that for that long, you know, 30 years, we have, well, 40 years now, we have been talking about this, you know, and so, and it still will continue, and it is in education. I'm sure in other professions, like I'm sure policing has a challenge. I'm sure addiction counselors have challenges, business folks and financial advisors and so forth. I bet they all have a burnout period where there's a bunch of folks that show up and have spent a lot of money to get educated in that profession, and then find out it just isn't the right fit for them. And so one way to get around that is these internships, right? And so I go out into that environment and then find out, is that really the environment that I want to work in? And if you think about it, you spend a third of your life in your job, 8 hours a day, there's 24 hours in a day, right? 8 hours is sleep, 8 hours is work, and 8 hours is your life. Do you want to spend 1/3 of your life in an environment that is unhealthy? You know, so it's a very important topic that affects everybody, not just nursing. Thank you again, Dr. Hover, for your time and your sharing of your research. I want to invite everybody else here in about the next 20 minutes to our second session of the day, which will be Dr. Manning, and she will be talking directly about teacher burnout, about nursing burnout again. And so we'll see how some of that research overlaps with Dr. Hover's, and maybe at the end of that, we'll be able to see if there's a combination of strategies for this area of interest. Anyway, everybody enjoy the rest of your day, and we'll talk to you soon.
All right, thank you, everybody.